So in the UK database that's been published, which audits our UK experience, the incidence ranges between 2.5 and 2.6% a year per annum for practice. So, and most of those strokes occur very early on. There is an incidence of some strokes occurring along a later time period, and the mechanisms of those strokes is different. So the very early ones are procedure related, and then the ones that occur over a later period are related to patient factors like atrial fibrillation. They may be related to the valve itself, but the major incidence occurs in very early on, within the first 72 hours of the TAVI procedure. And as I say, it runs along at about 2 to 3%. We don't really know exactly which factors predict stroke risk. There are some patient factors that we think do so, like age, atrial fibrillation, a heavily calcified valve, or if there's a lot of manipulation of equipment around the aorta, for example. So those factors can help to predict patients at increased risk, but there's no clear risk tool that we can use to identify exactly which patients are at higher risk from stroke. So the problem is that the occurrence of stroke during TAVI is unpredictable. And although we can think about factors that might be predictive, it's hard to tease those out at an individual level. It's about approaching each patient on a very individualized basis. So we know that there are patient factors, so things like atrial fibrillation and anticoagulation. There are some studies trying to address what the best anticoagulant strategies are. And then there are procedural factors. So for example, we might not want to necessarily use predilatation in a heavily calcified valve. Clearly we want to limit aortic manipulation as much as we can. Although we want to try and do that, the procedure is difficult to predict, and that's hard to change your procedure to limit some of the things that we would like to do. But no predilatation, limiting the aortic maneuvers, anticoagulating when you need to. Those are the sort of key things that we would focus on. So the cerebral protection devices are interesting. If you look at the data that we have for those, it comes from several sources. So if you look at patients having a TAVI with a device and you take the device out, you find debris in the vast majority of patients. If you look at patients who've had a TAVI, we know that many of them, if you scan the brain with an MRI scan, have lesions in the brain. And what we don't know is the effect necessarily of those lesions. And the trials that have been done haven't necessarily shown a major reduction in either these lesions or the incidence of stroke. There are some variation, but there's no large randomized trial looking at these devices. There are registry data, and they show a pretty consistent effect that the routine use of these devices lowers stroke risk from a 4 to 5% risk down to about a 2% risk, less than 2% risk. And if that was to be able to be repeated in a large trial, that would certainly suggest that cerebral protection may have a much wider role in TAVI. So I don't think we know exactly how and which patients might best benefit from stroke prevention devices. These are extra procedures. There is a time and a cost implication. And what we need to understand better is how effective these devices are. Are they most effective in certain patients? Are there patients where the risk of stroke is so low that the benefits are less? Are there other effects beyond major stroke? So one of the things that is important is not just disabling major stroke, but later neurocognitive decline. So whether these lesions that we identify on MRI affect later brain function. And we don't really understand the significance of those. So there are sort of competing questions. One is the let's prevent the big stroke, and the other is let's protect the brain. And at the moment, we need a lot more data to help us understand where these devices necessarily help us in those situations. We're in the process of establishing a randomised trial to investigate the use of cerebral protection in TAVI. That's at a very early stage, but the UK cardiology group have been very positive in initial discussions about supporting a trial.